So I just want to give some clarifications around the crisis standards of care that were announced last week. It's important to reiterate that these guidelines are voluntary, and at their core is to mitigate against unconscious bias in making critical medical decisions during a pandemic or crisis where there are scant medical resources. Some Massachusetts hospitals already had standards, others did not, and it is for that reason that these voluntary guidelines were requested and developed. Hospitals are urged to use these guidelines as a framework and adapt them in accordance with their own standards of care and in a manner that limits any inequitable impact on individuals and communities of color, immigrants, people with disabilities, and other vulnerable and historically marginalized communities. Hospital triage committees should include a diverse group of clinicians, including the hospital's chief diversity officer, human rights officer, or patient advocate. We hope that these guidelines, these templates, never have to be used, which is why, as you know, we are pursuing aggressively medical supplies, including ventilators, and setting up alternative medical care sites across the state to flatten the curve to protect our healthcare resources in preparation of a surge. We've been planning and continue to plan for the worst scenario with the fervent hope that these guidelines are never used. The guidelines explicitly call out the factors that have no bearing, include but not limited to race, disability, gender, sexual orientation, gender identity, ethnicity, ability to pay, socioeconomic status, perceived social worth, perceived quality of life, immigration status, incarceration status, homelessness, or past or future use of resources. They are irrelevant and not to be considered by providers making difficult decisions if that time comes. It is important to acknowledge that people of color, people with disabilities, individuals who are marginalized, and others who are particularly called out in the guidance are most vulnerable to illness, death, and burden of disease. We must work to mitigate these long-standing institutional barriers in order to improve equitable access to care and treatment. In the event that a hospital considered implementing their own crisis standards of care, there's an affirmative obligation to notify the Department of Public Health in order for DPH to monitor, intervene, and offer alternative options if they exist. The CSCs also provide for a process of rapid reassessment and an expedited appeals process. As we all know, New York, which is the epicenter of the pandemic, has not utilized their guidelines. No Massachusetts hospital is utilizing CSC guidelines. And frankly, if we had no ethically based guidelines for the fair distribution of scant resources of care, inequities would occur. Where are we today in terms of hospital beds and alternative service centers? In addition to monitoring daily bed utilization, we continue to have frequent calls with hospitals to monitor their capacity and monitor the ASCs, otherwise known as alternative service sites or centers. The percentage of available beds is about the same as it was last Friday when the governor spoke about this. We will also regularly post on our website hospital capacity on a daily basis. Just some numbers. The Boston Hope update as of last night, the overall patient total was about 36. And at the DCU, UMass Memorial is currently caring for 10 patients. So statewide, we have approximately 50% of our hospital beds are occupied, which obviously means that nearly half are available. Clearly, there are regional differences. However, I would remind everyone that given that we are seeing more than 2,500 confirmed cases, new confirmed cases a day, we won't know the full impact of whether individuals are hospitalized until the next 7 and 10 days. So this is just the eye of the storm. Thank you.